Assalamu alaikum. My name is Dr. Misbah Manzoor, and I'm working as a senior registrar in Department of Cardiac Imaging, Peshawar Institute of Cardiology. First of all, I would like to thank all of you to giving me a chance to participate in this prestigious conference. So today the topic of discussion is hypertrophic obstructive cardiomyopathy. So let us start with a basic introduction of understanding the hukam. So it is basically a genetic disorder that is inherited in an autosomal dominant fashion. It has a variable degree of penetrance and expression. The concise definition of defining hukam is it is an unexplained, marked, and often asymmetrical, it may be symmetrical, localized or generalized LV hypertrophy that is associated with a non-dilated ventricle in the absence of any cardiac or systemic disease that may be explaining the presence of hypertrophy. Regarding its prevalence, 1 in every 500 individuals are affected by the disease. It has no gender or racial predilection. It is often diagnosed in third decade of life, but it can occur at any age. It is the most common cause of sudden cardiac death in adolescents and pre-adolescents. So how can echocardiography help us in evaluation of hukam? According to 2024 AHA guidelines, it is a class 1 recommendation that transthoracic echocardiography is recommended as an initial investigation in all the patients with suspected hukam. So not only in diagnosis of the disease, echocardiography has a very pivot role in predicting the prognosis in the individual patients and also for planning and guiding the treatment modalities and testing their efficacy. So being an echocardiographer, you must adopt a systemic echocardiographic approach in order to evaluate a patient completely regarding hypertrophic obstructive cardiomyopathy. The approach should not only include the diagnosis, but also the prognosis and planning for the treatment strategies. So starting from the first point, you should establish a diagnosis and determine the pattern of hypertrophy. Following that, the presence and severity of LVOT obstruction, evaluation of MR along with the intrinsic mitral valve structure. Then coming to the prognosis, the prognostic points include LV systolic and diastolic functions, other prognostic markers including LA volume, LV apical aneurysms, and other features that will point towards a prognosis of in a particular patient. So starting with the diagnosis, the first step will be establish the diagnosis and determine the pattern of hypertrophy. So regarding LV hypertrophy in patients with hukam, it preferentially involves measuring maximum left ventricular wall thickness. The measurement should be made in all LV segments in a short axis view, a view that is orthogonal to the endocardial and epicardial. And it should include all the segments from base to apex, that is mitral, mid-LV, and apical level. And it should be recorded in end diastole when the LV has its maximal thickness. Regarding guidelines, the diagnostic criteria is maximal and diastolic wall thickness of more than 15 mm in any myocardial segment or in more than 13 mm in patients who have first-degree relatives with confirmed hukam. There is another measurement that is called septal to posterior wall thickness ratio, and it is quantified as more than 1.3 in normotensive patients and more than 1.5 in hypertensive patients to be diagnostic of hukam. Here you can also see that if the maximal wall thickness is more than 30 mm, so it is a risk factor for sudden cardiac death. So it will also point to a poor prognosis. These are the different errors that are usually made while taking the maximal wall thickness in the patient with hukam. You can easily see in the first picture that it has erroneously included the septomarginal tuberculation and aberrant LV papillary muscle. These extra structures should be always included from the measurement, and as depicted in this picture, the measurements should be taken at all the levels, including the mitral, papillary, and apical levels. So these are the common mistakes that should be taken care of. The pattern of hypertrophy in hukam may be asymmetrical or symmetrical. However, 95% of the times it is asymmetrical involvement, mainly involving the anterior and inferior septum, followed by the other territories. 5% of the cases may be symmetrical. Here in the next diagram, you can easily see different phenotypes of hukam. The first one shows the reverse septum. The second B is showing a neutral septum. C is showing the apical hypertrophy and followed by a sigmoid septum. So these are various phenotypical forms of hypertrophic obstructive cardiomyopathy that you may encounter. The next step is assessment of LVOT obstruction. So although the presence of LVOT obstruction is not necessary for the or mandatory for the diagnosis of the disease, but it forms the basis of symptoms generation, and it is helpful for deciding the initial therapy. LVOT obstruction in Hukam is always dynamic. It can be measured at rest and with provocation maneuvers. It usually changes with different preload and afterload conditions, and also changes with changing contractility of the heart. Different maneuvers that we use for measuring the LVOT obstruction include physiological and pharmacological maneuvers. Physiologicals mostly practiced in our labs are Valsalva, standing or squatting, standing from squatting or exercise. And pharmacological maneuvers are using amyl nitrate, and in very specific cases we can use dobutamine stress echo, but when the patient cannot exercise. Guidelines about this obstruction says that any resting or provocation peak LVOT gradient of more than 50 millimeter of the mercury indicates obstruction and mandates need for surgical or percutaneous intervention. And whenever you are not finding a resting peak LVOT gradient much significant, that is, if it is less than 50, then you must apply the provocative maneuvers, and this is the class 1A recommendation. These are the signals that you will get by putting a continuous wave Doppler and apical 5 chamber view. These are the particular dagger shape appearance when you get LVOT obstruction, and it is showing an late systolic peaking. However, this signal should be differentiated from the signals of mid-ventricular obstruction and signals of MR. So usually the signals of MR start early and during the isovolumetric contraction phase, and they usually last up to isovolumetric relaxation phase. Signals of MR usually have high velocities, and they are more rounded or parabolic in shape. However, as you can see in the LVOT obstruction, the signals are usually dagger shaped with a blade, and they have late systolic peaking, and they usually end up in the late systolic phase. So this is the diagrammatic representation of the augmentation of these gradients following various maneuvers such as Valsalva and exercise. So next step is the detection of presence of MR and its severity. So the mechanism of MR in Hukam is basically as a result of the LV outflow tract obstruction, there is an effect called Venturi effect is created. This effect creates a negative suction pressure that will cause a dragging force on the mitral valve apparatus, dragging the anterior and mitral leaflet as well as the posterior mitral leaflet towards the LV. This will result in systolic anterior motion of the anterior mitral valve leaflet, and finally resulting into malcoaptation of the mitral valve that will result posteriorly directed jet of MR. So the MR in Hukam should be mid or late systolic and posteriorly directed. In any other case, that is in the case of anteriorly directed MR or centrally directed MR, you should do a TE and a TOE and should exclude other intrinsic valvular abnormalities because they are very common in the patients with Hukam. So below is the diagrammatic representation of different intrinsic abnormalities of mitral valve apparatus that may encounter in the patient with Hukam. So till now, we are done with the diagnosis of the disease. Following that, the next step in the echocardiographic approach is prediction of the prognosis. So in the prediction of the prognosis, the first step is to measure the LV systolic function. So depending upon the disease stage, there are two stages of the disease. One is the earlier stage and other is the later or terminal or burnt out stage. In the early stages of the disease, you may have a normal EF and normal fractional shortening. But the subclinical systolic dysfunction should be picked up here by strain imaging or speckle tracking because it correlates directly with intramyocardial fibrosis and LV wall thickness. Here, a global longitudinal strain of more than -10 in more than 3 out of 18 LV segment is independent predictor of non-sustained VT. However, in the terminal stages of the disease, as already fibrosis have occurred and you have a dysfunctional LV, so you will have a reduced EF and a reduced fractional shortening. And here the mortality has been increased to 11% per year. So these are some of the strain imaging. In the first diagram, you can see the septal hypertrophy. Corresponding to that, there is a reduced strain in the septal segments. In the C figure, you can see an apical hypertrophy pattern, and Complementing that is the GLS that is showing reduced strain in the apical segment. LV diastolic dysfunction is very pertinent to be measured in the patients with a HOOCM because regardless of the symptoms and regardless of the systolic dysfunction, patients with HOOCM develop the diastolic dysfunction in very earlier stages of the disease. Patients with a restrictive LV filling pattern may be a high risk for adverse outcomes even with a preserved ejection fraction. So these are the various predictors that are used for measuring the LV diastolic dysfunction, and they're almost similar to as were discussed earlier. Other predictors of poor prognosis include LV apical aneurysms, and it can be best demonstrated by doing a transthoracic echo with contrast. The presence of apical aneurysm causes an increased risk of sudden cardiac death. Left atrial ventricular index more than 27 ml per meter square causes an increased risk of heart failure development. And so is the left atrial diameter indices. The next function of the echocardiography is to guide the management once a patient is diagnosed with the HOOCM. So it has a very important role in planning and guiding the septal reduction therapies and their efficacies. Various preoperative measurements are used, but the most common ones are measurement of maximal septal thickness, anterior leaflet length, and apical extent of the septal bulge. These all measurements help us a proper pre-procedure planning of the procedure. And it also helps in identifying the appropriate septal perforator that supplies SAM septal contact. It is usually obtained by intracoronary ultrasounds. Newer echocardiographic techniques have their own function and their own role in further diagnosis and delineation of the disease mechanism. For example, for 3D echo, it gives us an insight into the mechanism of SAM and deformational geometry of the LVOT. Transesophageal echo is adopted where you do not have good transthoracic echo windows, or in patients where LVOT obstruction mechanism is not clear, or where you have to assess the mitral valve apparatus before a septal reduction procedures, or where you suspect intrinsic mitral valve abnormalities, or in the perioperative setting. Contrast echo has a good value in enhanced endocardial definition and to evaluate myocardial perfusion. And as I've discussed in the alcohol ablation therapies, it helps us to delineate the extent of septal infarction that needs to be done. So next is a case presentation that we had a 27 years old male who came to the outpatient department with history of multiple episodes of syncope on exertion and palpitations. There was no family history of sudden cardiac death. On examination, he was all fine except an ejection systolic murmur that was heard at the left parasternal border that was increasing in intensity with Valsalva maneuver. ECG showed LVH with normal sinus rhythm. He was referred to us for transthoracic echo. These are the transthoracic echo images of the patient. As you can appreciate in the first slide, it is a parasternal long axis view, and it is showing the asymmetrical pattern of hypertrophy that can be appreciated. However, and also there is SAM. And in the second clip, you can easily demonstrate a posteriorly directed jet of severe MR and LVOT gradient that is observed as a color flow in the LVOT. This is the M mode that we obtain. You can clearly identify the asymmetrical hypertrophy and SAM in this M mode. This is the apical 3-chamber view that is showing the mitral regurgitation along with the LVOT obstruction. These were the gradients that we obtained in this patient at rest. So there were the gradients of resting gradients of almost 86 millimeters of the mercury in these patients were at rest. So the patient was diagnosed as a case of HOOCM with LVOT obstruction. So take-home messages for this presentation is comprehensive echo is indispensable for diagnosis and hemodynamic assessment of HOOCM. Echocardiography plays an important role in clinical risk stratification and also the interventional management of the patients with HOOCM. New echocardiographic modalities, including 3D echo, contrast echo, and transesophageal echo, have a significant role in further delineation of pathological details and should be used when needed. Thank you.
Excellent presentation, crisp echo images, and timely, like time management is good. So for the interest of time, the panelist comments I will take at the end, and I can take one question from the audience and no cross discussion. Any question, yeah.
The labeling of HOOCM
Uh,
Secondly, you have pointed out the Venturi effect. There was a paper in circulation, I think in 2050 or 60, in which they negated this. And there are other mechanisms also of MR, like the lengthening of the body and the
Yeah.
alignment of the family muscles, which must also be good for the network.
Okay. Okay. Thank you.
Is there any genetic predisposition? I mean, can it occur in the family? We have a family in Quetta, 4 or 5 members, all have.
Short answer.
Is there in the literature there is a heredity or
Sure.
genetic predisposition of?
Yes, sir. It is inherited in autosomal dominant fashion, so it do run in families, sir. There is genetic predisposition for this disease.